Good morning. Thank you all for coming. It's just a great audience here. So what I'm doing today is speaking for nurses and all the team members who implement care in low and middle income countries. So it's such an honor to be here. It's also a tremendous responsibility because I represent their voices. So I've been working in low middle income countries now for almost 13 years. And I mean, it's a life-changing experience. I think I will never stop. I'll have to be, like too old to do it or something, but I love it. And I've learned so much. I mean, when I started, I had a lot to learn. I didn't know anything. But one of the things that I learned absolutely right away was the needs of those who implement care. And their needs are great. And that's what this will focus on today, because without their needs being met, we're not going to close the current survival gap. So today I'm going to talk about the key to closing that gap, the critical first step and the critical second step, which is implementation of quality care, which requires a team approach. The delivery of care. Okay, so the delivery of quality care, I'm going to define what I mean by quality, is directly linked with implementing the baseline standards. And the scientific evidence that supports that fact, there's strong science behind all the standards and the future direction. So I have nothing to disclose. Now, let's just go over the survival gap. So the survival is 83% in high-income countries. That's a miraculous achievement. However, in low and middle-income countries where most children live, it's 20 to 30%. So 87% of the children of the 430, this is the estimated number of children. They live in low and middle income countries, and a third are not even diagnosed. So I like to do the math and just make it very clear. Of the estimated 430,000 children, this is high, low income countries. If 87% live in low middle income countries, that's 374,000. Now, if only 25% survive, that's 280,000 deaths every year of children, and that's just not acceptable. And the WHO agrees. So they have an initiative on childhood cancer, and their goal is by 2030 is 60% survival. Okay, so 60% survival is the overall, that's the mean. Right now it's 37%, so that's a very I think, ambitious goal, but it's very doable. That would actually save almost 1 million lives is what the estimate is. So with that 5-year survival, there is a very broad range. In Eastern Africa, it's 8% compared to North America, which is 83%. So I'm trying to make this very clear. The first step is critical, but so is the second step. The first step, you've got to get an accurate early diagnosis, no question. Appropriate treatment plan, prescribed, you have to have the right protocol. Available drugs, I thought of another A last night, access to care. So this is the first step, and we focus on that. But we have to focus on the critical second step too, and they have to be done concurrently. The second step is quality implementation, and it's directly linked with outcomes. So when I say quality, what does that mean? Okay, I'm going to explain that. It's not just a term that has no meaning. It's very clearly implementing the treatment plan appropriately, accurately, effectively. You have to have a very high skill set to implement pediatric oncology care this way. And that's what quality is. It's doing it right. And that's what I'm going to talk about. So if you achieve step 1 and don't combine that with step 2, we're not going to change that survival gap. Now, okay, so when I first started, I would go to all different countries, talk to the nurses, and it just was overwhelming. They have so many needs. But what impressed me so much was their desire to provide quality care, to do what was right for their patient. And they were frustrated just because they didn't have the resources and the support to do what they wanted to do. So that's really a big issue here. We have nurses implementing care without the resources, support, and specialty oncology skills that they need to do it the way they want to do it, in the way that will make a difference and save lives. So let's look at the teams and compare them. In high-income countries, boy, we are very specialized. Up to 20 different team members. That's the ideal, perfect world here. Low middle-income countries, it's the physician and the bedside nurse, the whole staff of nurses. Now, okay, you have a social worker, psychologist, a nutritionist, a pharmacy, but these are hospital-wide. I mean, they serve often a 500-bed hospital. So you can't call the nutritionist to come teach your family. You can't always call the social worker or the psychologist. They're just not available. So what happens? So healthcare providers, the whole team members have to take on these specialty roles. So because there's limited access to nutritionists, psychologists, social workers, and pharmacists, the responsibility almost always falls to nurses. So an example of this is nurses in most low middle-income countries not only deliver chemo, they prepare it. There's also limited access to medical personnel, nights and weekends, and so what happens is, if you could imagine, they have to make those critical decisions themselves. Now, with resources and technology, that decreases efficiency and makes the workload higher. So what you have is almost a perfect storm. You have tremendous responsibility without the support, resources, specialized training to do the job. So what's the answer? This is why our group created the baseline standards. This is the link with providing implementation of the treatment plan that can save lives, that can give the best possible outcomes. First of all, the standards are not punitive. I mean, that's not why they were created. They're created as guides. They're to help us clearly define what the needs are. This is putting something that could be very vague into something that's very doable, almost putting metrics to it, this is very important. Usually I can use the standards as an initial assessment, and then we work in phases to achieve it. And it's an organized approach to improving care, supporting the nurses, and the nurses and the team members know that we use this to give them the resources and support they need. Now, and I'm going to go through the standards, and then I'm going to talk about the science. Every standard is clearly based on a large body of scientific evidence. Sorry. Okay, this is our team. I think most of our team is here today. We are a subgroup of the Pediatric Oncology in Developing Countries Nursing Working Group. Okay, we are a super dynamic team. We have worked together for 10 years. We share a common passion, common goal. We developed the standards. It took us about a little over a year and a half to get consensus with the entire group. They were first published in Lancet Oncology in 2014, in a longer version in Cancer Control. We have endorsements around the world of 22 institutions, and we have an advocacy group. So we've been busy. Now, also, we've had just 2 recent research studies published. The first one assessed the ability of pediatric oncology centers to meet the standards, and the second study, secondary data analysis, determined the proportion of hospitals that met, partially met, did not meet the standards, and also what were the predictors of non-achievement. So nurses from 101 hospitals in 54 countries and 6 WHO regions completed the survey. This confirmed what we knew from our assessments, but we certainly did not have this much data to go on. But nurses consistently in low middle income countries reported that they worked environments that do not meet the standards. The first study was led by Lisa Morrissey, was published in Pediatric Blood and Cancer. The second by Courtney Sullivan, and it was in Cancer Nursing, and it's still in press, but so I don't have a cover. Okay, so I'm going to go over the standards. They are really simple, and that's good. They're to the point. And then I'm going to talk about the science that supports each standard. So the first standard is very, very important. Staffing should be based on acuity. Children with cancer are sick. They're some of the sickest, most require the highest level of nursing care of almost any pediatric patient that's sick. And I've worked in all areas of pediatrics, and it really does require the highest skill set. So there should be 1 to 5. Unless they're in ICU or bone marrow transplant, and that's 1 to 2. They should not rotate services. I remember when I first started, it was like I could not figure out why every month in some hospitals, nurses it was like musical chairs. The end of the month, okay, everybody move to another unit. And I kept asking why, and they would always say, well, we want them to know how to do everything. Well, okay, but that's not a good idea. So that really, we can't prepare our nurses to be specialists and provide the care that's needed if they're transferring to other units all the time. Okay, orientation. Even in high-income countries, and I'm at a university, we don't teach anything about pediatric oncology, okay, nothing. We do pediatrics a little. So it's incumbent upon the hospital to fill that gap, and that's not happening in low middle-income countries. They don't have the staff to do that. There's nobody there with that specialized skill to even train the new ones that come in. So we're very clear on what is required for orientation and a checkoff on competencies. The third one is also education. You have to have ongoing education. You can't just, hit them up front with a couple of weeks. And this is really, right here, the education and the staffing, but all of the standards, they work, they're in synergy. You can't just pick and say, well, I'm going to do this one and not any others. Just think if you had a very educated nurse who had all the skills, but she had 20 patients or 15 patients, that doesn't matter. Or if she just had 3 patients, but she didn't have the skill. So those two have to go hand in hand. Oh, teamwork. Okay, this is so important. Nurses must be acknowledged and included in the team. I've seen so often where nurses sometimes even didn't have access to the charts. But nurses, because they're the ones that spend the most time with the patient and often have the trusting relationship, they can't teach and their family or really provide the care if they don't understand and know exactly what's going on with their patient. Certainly resources for safe care. I don't know if anybody can remember not having IV pumps, but having to do it by hand, manual. I can. That means I'm old. But that's what many places don't have. So obviously that just increases the workload. And so many of the nurses mix chemo, but they don't have any protective equipment. My first experience was seeing a nurse who was, I think it was a closet, and they took the door off, and she was, her back was to the outside, and she had mixed chemo every day. And she'd been doing that for many years with no ventilation, no protective equipment. And evidence-based. Nurses need guidelines to provide care. You need standards and guidelines based on evidence, policies. So, okay, now for the science. Now I'm going to take each standard and give you the science. The first one was staffing. Now there's a large body of evidence, and I could talk, a long time about this, but I'm going to give you the two landmark studies, okay? New England Journal. This looked at the level of nurse staffing in hospitals and the relationship to adverse outcomes. They looked at almost 800 hospitals, 6 million patients, so large study. The greater number of nursing hours of care per day was significantly associated with a shorter length of stay. Okay, now that's a cost savings too, okay? So this is important. We have to be realistic and talk about money. Lower rates of complications, that's a money saving. Lower rates of failure to rescue. Okay, so what is failure to rescue? This is where staffing and education both come in. With pediatric oncology, we all know our patient's condition can change in a few minutes' time. Perfect example is sepsis. If that is not picked up, if you don't pick that up in that window of opportunity, you're not going to be able to turn that patient around. Sometimes not even in the best ICU. So that's what failure to rescue is. Now, another landmark study, American Medical Association, after adjusting for patient and hospital characteristics, each additional patient per nurse was associated with 7% increase in likelihood of dying within 30 days of admission, and a 7% increase in the odds of failure to rescue. Sometimes when I present this about the staffing, I always have people say, well, if I go to the hospital, I'm going to find out what the nurse-patient ratio is. That's probably a good idea. You probably should ask that. Now, all right, this study estimated if a nurse had 8 patients, but if that was decreased to where a nurse had 4 patients, that could potentially be 500 preventable deaths for every 100,000 admissions. Now, the cost benefit, like I said, the reality is we must talk about money. These are projected estimates of increasing proportion of nurse hours to 75th percentile. It would result in decreased decreased length of stay, decreased complications, and save lives, with an estimated short-term savings of $242 million. Now, staffing does cost, obviously. In low and middle-income countries, the nurse's salary is usually very low, but you can't look at it like that. You have to invest in nursing or you're not going to save lives. It's like if you invest all the money in step 1, but don't invest it in step 2, that's not a really good decision. Even financially, it's not a good decision. So now this study is very relevant. And I worked with this physician that led this in Zambia, and they've looked a lot with nursing education and outcomes on neonatal mortality. One study showed a 6-month training course for nurse midwives, and it actually decreased neonatal mortality by 40%. So, also looking at cost, you can see there are many models for providing nursing education. And this is the one that we costed out. And the very low one, that's the cost of a full-time nurse educator. And that includes the cost of training that educator to be a specialist. And you can see in the other models are bringing people in from high-income countries or bringing people from low-middle-income countries to high-income countries. And those are okay, they're expensive, but they're also not realistic. When you have an educator there that's every day, then that educator is supported. Now you have to support that educator. Then that's the best model and the most economical. So teamwork. Okay, I'd love to talk about PEWS, Pediatric Early Warning System. This is nurse-administered clinical acuity tool used to improve early identification of clinical deterioration. So this is, it's a great communication tool. And with nurses, and especially when I first started working to implement this, it was with nurses that were new graduates, and they actually, it was so helpful to them. And in low and middle income countries, it's so helpful too, because often the nurses, if they contact the doctor and say, I'm worried about this patient, they have trouble actually, expressing exactly what they're trying to say, and sometimes it gets ignored. With PEWS, it's very objective. It's based on a score. And then there's a defined intervention based on that score. So this was implemented in a low middle income country just recently. It decreased clinical events significantly. It decreased ICU utilization by 21%, and that's where the money savings comes in. So you had 475 fewer ICU days. That resulted in, this is really just a little over a year, $354,000 savings. And that's net after the cost of implementation, which was not that high. But this really represents a team working together, nursing, physicians, the whole team approach. Okay, standard 5 resources, and certainly, there's evidence for all the resources needed, but the chemotherapy and what's needed for that is very clearly stated in the guidelines, and that's based on National Institute for Occupational Safety and Health and the Oncology Nursing Society guidelines. So there are many studies that really support the standards. I tried to pick out the ones that try to find ones that were done in low middle income countries. But this study was perfect, was done in a low middle income country for ALL pediatric patients. And what they did was the nurses didn't have any guidelines for caring for the patient. So they implemented evidence-based practice nursing guidelines. And by implementing them, first they had to develop them, and then they had to teach nurses how to use them. And it was significantly correlated with decrease in adverse events, both incidence, duration, and severity. So, and I like this because this is exactly what I've been saying, is pediatric patients in low middle income countries are treated with therapeutic protocols that detail the medical treatment. However, there are no protocols or guidelines for nursing care. So you have to have both. Again, it's just like step 1 and step 2. They've got to work together. Okay, so we have one study that represents what can happen when you implement all the standards. And this looked at, the outcome was abandonment of treatment. The rationale for that was that when nurses have fewer patients, they're educated, and part of our education is teaching the nurses how to teach the family that communication will improve and families will understand why they need to come back. I've done just a lot of work, and we don't call it abandonment of treatment in the U.S., but with families that had a history of not bringing their child back, and it's really based on trust and that communication. So this was a very population-based sample. It wasn't random sample. Almost 2,000 patients. The intervention was really the standards. So we changed staffing from 1 to 7 to 1 to 5, 1 to 2 for critical care. We hired a full-time nurse educator, educated the educator, and supported the educator, implemented quality standards, nursing guidelines, improved communication. So pretty much we did the standards. Now what happened? Abandonment of treatment significantly decreased pre and post. That we looked at 12-month cumulative incidence. So it went from 10% pre in the intervention site to 6%, 6.5. The control site started at 13 and went up to 14. So the two nursing care that meets the standards reduces the causes of treatment failure in low middle income countries. Two of the main causes, abandonment of treatment and toxic death, are directly related to nursing. So for the critical first step, and there's no question what that is. I might have left out another A, but accurate early diagnosis, appropriate treatment, available drugs, access to care. You've got to do that first. But you can't do that. You need to do the second step at the same time. They need to be implemented at the same time. So I use the example of hiring a famous architect to design a building, and he does a beautiful job. You pay a lot of money. It's gorgeous. It's going to be a beautiful building. But you hire workers that don't have the expertise to do it. You don't hire enough workers. You don't give them any lunch. It just won't work. You've got to have step 1 and step 2, and you've got to have the support for the people who implement care, the implementation team. So the standards are directly linked with quality implementation. So it's like I said, I always feel like I say quality, and nobody, what does that mean? I mean, it clearly is measurable, and you have to have certain things in place to be able to do quality interventions, and that impacts survival. So additional cost of support for quality implementation can be offset by the benefits of reducing adverse outcomes, length of stay, and saving lives. In interprofessional teamwork, some of that's just free, including nurses and other team members in rounds, patient care conferences. And certainly the implementation of PEWS is an excellent example of something that's very much, you can save money. Not that it's free, it actually saves you money. So disseminating, measuring, and meeting the standards is essential to SIOP's mission. And the standards have actually now become SIOP baseline standards. So, and it is the focus of our nursing working group activities. We are dedicated to seeing these standards implemented. So future research, we're planning our future research. We want to look at the impact of implementation of the standards. We have one study that shows that, but we'd like to measure it on more outcomes. and across varied settings and do an actual cost-benefit analysis. I don't have this study, completed yet, but I do know that the second step is going to be less expensive than the first step. So I had a question slide, I don't know where it is, but anyway, I would love to answer questions. Thank you so much for your attention. Thank you.